Welcome back to the DjamgaMind USA series. I'm Etienne Newman. Today we are talking about the law that is quietly bankrupting hospital margins, the No Surprises Act. On the surface, it sounds great, protecting patients from surprise bills. But for hospital revenue cycle leaders, it has created a bureaucratic nightmare. We are talking about good faith estimates that need to be accurate within $400, or you don't get paid. We are talking about baseball-style arbitration, where you either win all of it or lose all of it. And we are talking about fines of up to $10,000 per violation. Our AI agents are currently debating the financial fallout in the boardroom. Let's listen in.
Welcome to the Deep Dive. Today we're tearing the lid off one of the largest and frankly densest financial documents Congress has ever produced. It's the Consolidated Appropriations Act of 2021. You've probably heard it called H.R. 133.
And this thing, it wasn't just a bill. It was a $2.3 trillion behemoth. It funded, well, virtually the entire government and really dictated the financial health of public services, especially healthcare.
So our mission today is a little different. We're throwing you, our listener, straight into a crisis meeting. Imagine you're an executive. You're trying to find operational stability, maybe some cash flow, and just clarity inside this gargantuan text.
Exactly. We're going to forget the broad policy goals for a second. We are hunting for the specific financial figures and the regulatory traps that really define whether you survive operationally.
It's a high-stakes scenario. I mean, picture a CFO who is obsessed with immediate cash flow, sitting right across from a compliance officer who's just terrified of an audit.
And they're both staring at this one document, a document that's structured less like a law and more like a chaotic financial library.
That structure is the first shock, isn't it?
It really is. I mean, H.R. 133 combines dozens of these massive divisions. You think you're reading about public health, right? But you're actually holding the appropriations for energy, for defense, for education, all just bound together.
So to find the rules for your hospital, you have to dig for, what was it, Division BB?
Division BB for private health insurance and public health provisions, or, Division CC for health extenders. But they are buried, just buried deep among sections that have absolutely nothing to do with them.
So your agency's most vital financial blueprint is what structurally linked to the rules for agricultural subsidies.
Potentially, yeah. It just makes navigating the whole environment feel like walking through a labyrinth.
A labyrinth designed by a very bored accountant.
It really creates this institutional friction, because if a question comes up about funding in, say, Division BB, the answer might actually be hidden in the general provisions, or a transfer authority listed way back in Division D.
So stability is impossible when your money is tied up in a document that also funds every other corner of the bureaucracy.
Exactly.
Okay, let's step into that CFO's office then. Right now, the only thing that matters is scale and securing the money. So let's start big picture. How much cold hard cash did this act actually commit?
The scale is, well, it's just stunning. And we have the specific figures right from the text. If you look at Medicaid, payments to states under Title IXX of the Social Security Act, H.R. 133, authorized $148,732,315,000.
Wow. That's nearly $150 billion.
$150 billion. And that's just for the first quarter of fiscal year 2022. That cash is the immediate lifeblood for state healthcare systems.
Just for 3 months. That's a powerful torrent of money. What about the big federal programs like Medicare?
The numbers there are even bigger. H.R. 133 earmarked $439.514 billion.
So almost $440 billion.
Just about. And that's to sustain the Federal Hospital Insurance Trust Fund and the Federal Supplementary Medical Insurance Trust Fund. These are the funds that directly pay providers, pay hospitals through Medicare.
So together you're talking about more than $500 billion. The raw fuel for the entire system.
That's right.
Okay, but this is where the conversation gets tough.
Yeah.
Because the CFO sees those huge numbers, but they know not all of that money actually makes it to patient care. There's a hidden drain.
There is. This is the administrative cost of doing business with the federal government, and it puts enormous pressure on margins.
How much are we talking about?
Well, the legislation explicitly carves out transfer permissions for CMS, the Centers for Medicare and Medicaid Services, just to run its own show. The Secretary of Health and Human Services can transfer up to $305 million from those massive trust funds.
Wait. So out of that $440 billion for Medicare, $305 million of it just goes to pay for the administrators, for the software, the overhead, just to manage the program.
Yes, exactly. That money never touches a patient. It's the operational toll, the cost of the system itself.
So the CFO looks at that $300 million and just sees a mandatory reduction in their margin.
A multi-million-dollar reduction right off the top before any provider sees a dime.
And then there's the timing. The cash might be appropriated, but getting it into the bank account is a whole other battle. What's the fine print say about how quickly these payments actually get made?
This is the operational red tape that drives CFOs crazy. Look at Medicaid reimbursement. The law says payments may be made for any quarter, but only if a state plan is submitted in or prior to that quarter and then approved in that quarter or any subsequent quarter.
So if I'm a small clinic, that language basically makes me a short-term lender to the government.
It does.
I provide the service in quarter one. The state submits the paperwork in quarter one, but the federal government doesn't get around to approving it until, what, quarter three?
That lag time is entirely possible. It's built right into the bureaucratic structure. That uncertainty around the approval timeline translates directly into unstable revenue and unpredictable cash flow. The money is there, but the bill makes it a nightmare to predict when you get paid.
Okay, so we've got the cash inflow and the administrative drag. Now let's switch chairs. Let's talk about the compliance officer's deep anxiety. Because once the money's in the system, that's when the nightmare of audits and fines really begins.
Right. And the sword of the Inspector General is very well funded. The money is targeted. H.R. 133 provides $30 million for the Social Security Administration's Inspector General, plus another $75.5 million transferred from trust funds specifically for fraud and abuse detection.
So it's over $100 million just dedicated to finding fault. They're not waiting for complaints. They are actively resourced to hunt for misuse.
And that scrutiny goes beyond just the big federal programs. It extends right into the research world.
Which people often think of as being separate.
Exactly. The NIH, the National Institutes of Health, sees a direct transfer of $5 million to its own Office of Inspector General, and that money is explicitly for oversight of grant programs to ensure the, quote, integrity of its grant application evaluation and selection processes.
So even if you're a grant recipient, the compliance risk doesn't end when you get the check. You are subject to active funded audits.
All the time.
That's scary enough. But the second big fear is rescission, right? The idea that revenue can just disappear overnight. If I have funds set aside, can Congress just claw them back?
It's a profound risk, and this act proved it happens. H.R. 133 had concrete examples. For instance, $500 million was rescinded from unobligated balances that were meant for student financial assistance.
As $1 billion,
Yeah.
just gone. So if you're an executive who planned a multi-year budget relying on that money, your whole financial plan just evaporated.
That's the vulnerability. We also saw $12 million rescinded from the distance learning and telemedicine program. These aren't just minor adjustments. It's a clear signal that money you thought was safe can be recalled by Congress at any time.
It forces you to operate with a healthy dose of paranoia.
Absolutely.
And it gets worse, right?
Yeah.
Because there's also heightened scrutiny on contractors. So the compliance officer has to worry not just about their own mistakes, but about their vendors' failures too.
The language there is crystal clear. It says none of the funds can be used to pay award or incentive fees for a contractor whose performance is judged to be, and I'm quoting here, below satisfactory performance, or that does not meet the basic requirements of a contract.
Let's unpack that. So my agency hires a tech vendor to build a reporting system with federal money.
Mhm.
The system's buggy, it fails an audit.
Mm-hmm.
Even if I paid the vendor in full, my agency is now on the hook for misuse of funds because the contractor failed.
Precisely. You are held responsible for the performance of your subcontractors when you're using federal dollars. It makes choosing a contractor a high-stakes compliance function, not just a procurement decision.
Okay, let's move to the third big challenge, operational pacing. The law sets these mandatory, rigid deadlines that just create an impossible pressure cooker.
Yes, and we need to see the bill not just as a funding document, but as a mandatory project management schedule. A perfect example of this is the timeline for certain FEMA grants. The statute mandates that applications have to be available to applicants no later than 60 days after enactment.
60 days, that's rapid to get an application out the door.
Then the applicants have to submit their applications no later than 80 days after the announcement. And this is the crucial part. Once the application is in, the administrator must act on it within just 65 days.
So that 60, 80, 65-day clock is law. The bureaucracy can't just slow walk the review. If they miss that 65-day deadline, they're literally breaking the law no matter their staffing shortages.
The pressure is non-negotiable. And on top of that, even routine actions get delayed by political reporting. The Secretary of State, for example, has to notify the Appropriations Committees 15 days in advance before committing certain funds.
15 days. So an administrator sees a critical need, a necessary fund transfer, and they can't just do it. They have to draft a notification, send it to Congress, and then just wait while a political clock runs out.
It introduces so much inflexibility, and you see the same thing in HHS transfers too, often a 10-day window. This rigidity is reinforced by a general provision that just bans quick fixes. The bill makes it clear you can't transfer funds to any agency except pursuant to an authority provided in this or another Appropriations Act.
That really hammers it home. Every single dollar transfer has to be traceable back to explicit written authority in this massive document. The whole system is designed to prevent quick, improvised solutions.
It really is. It forces your planning to always prioritize statutory compliance over speed or efficiency.
So let's bring this all back to our listener. We've navigated $500 billion in funding, we've seen the administrative drain, the $500 million rescission risk, and felt the stress of those 65-day deadlines. What's the ultimate strategic takeaway from all this?
The aha moment, I think, is realizing that the financial crisis is structural. You just can't understand your agency's funding in, say, Division BV without understanding the whole omnibus bill. You have to know that it also contains Division D for energy and Division E for financial services. The rules for your public health program are just intrinsically linked to the same chaotic framework that funds the Department of Defense.
So it's the sheer weight of it all.
Yeah.
You have to accept that your program is always operating inside this massive, multi-departmental financial document.
Exactly. And that forces you to focus ruthlessly on predictability. You have to anticipate political risk, you have to budget for the administrative drag, and you have to build all your processes around these non-negotiable deadlines.
Flexibility is not an option.
Meticulous documentation is.
Which brings us to a final and maybe the most important detail, one that really underscores who's in control, even over the most basic necessities.
Yes. There's this one specific provision buried deep in the text. It says that funds made available for salaries and expenses can remain available through September 30, 2022, but only if a request is submitted to the Committees on Appropriations for approval prior to the expenditure of such funds.
Hold on, let me get this straight. The agency has the money. It's for payroll, the most basic need. Congress is letting them extend the deadline to use it. But before they can actually pay their employees, they have to get advance political approval from a committee.
That is the requirement. Even when flexibility is granted, like extending a time limit for payroll, the ultimate bottleneck is entirely political. The money is available, but the executive branch's authority to spend it is subject to mandatory advanced approval from Congress.
It's the ultimate check on the system.
It is. It shows that at the highest levels, operational autonomy always comes second to political control. And that's something you just have to plan for every single fiscal quarter.
I just saw the monthly report. Why is 15% of our self-pay revenue sitting in pending dispute? We used to collect this in 30 days. Now it's sitting there for 6 months.
Because of the GFE discrepancies, David, the good faith estimates. We sent out estimates for $2,000, but the actual surgery had complications. The bill came to $2,500.
So what? It's surgery. Things happen. Send the bill.
We can't. Under the No Surprises Act, if the final bill exceeds the estimate by more than $400, the patient has a federal right to dispute it, and they win every time.
That's a rounding error in healthcare. So we just eat the cost?
Either we eat the cost or we risk a federal investigation. And remember, the penalty isn't just a refund. It's a civil monetary penalty of up to $10,000 per violation. Do you want to risk a $10,000 fine to collect an extra $500?
Fine. What about the commercial payers? The insurers are lowballing us on every out-of-network claim. I told the team to send them all to arbitration, to the IDR.
The IDR is broken, David. The backlog is over 100,000 cases, and the administrative fee just jumped to $350 per case. Even if we win, we are spending months of cash flow just to fight for pennies.
But it's baseball arbitration, right? The arbiter has to pick our number. Our rates are fair.
They pick the number closest to the QPA, the qualifying payment amount, which is basically the median in-network rate. If our offer is too high, the arbiter picks the insurer's lowball offer. We lose everything.
This is a trap. We can't balance bill a patient, we can't fight the insurer without paying fees, and we can't miss an estimate by $400.
Welcome to the new revenue cycle. I need budget for better front-end software. We have to get the estimate right before the patient walks in the door.
That was the reality of the No Surprises Act. The takeaway is brutal. The days of bill now, figure it out later are over. If your front desk staff misses a good faith estimate by 1 day, or if your estimate is off by $401, that revenue is effectively gone. For CFOs, the Independent Dispute Resolution, IDR, process is not a safety net, it is a bottleneck. To stay ahead of CMS mandates, subscribe to the full USA series at DjamgaMind.com. We are tracking the money so you don't have to. I'm Etienne Newman. See you in the next briefing.